Hello, guys. Welcome to another of Mental Health with Nana Yabua. Yes, my name is Nana Yabua. In this particular webinar, we are going to go through maternal mental health. Maternal mental health here in Canada is a huge issue in the sense that Black women, Black maternal mental health, Black women don't have the opportunity or are not being looked at. So that is what this webinar is about. Um, so here we go. It is a five-part webinar, but considering time and everything, I'm going to take care of the first two or three prominent ones, and then at a later time, we're going to go through the next session as well. So let me quickly pull it up here, and then we go through this. So here we go. Black maternal mental health before, during, and after childbirth. So that is what this conversation is about. So, what you learn, the key aspects you're going to learn are trauma in labor and delivery, that is PTSD. Yes, in labor and delivery, women also go through PTSD. Going through the baby blues, postpartum depression, and postpartum psychosis. What it is, what to look out for, and how to treat it. So, before we go through anything, as we are here in Canada, we know that Canada is a land of the indigenous, the indigenous. So we're going to do the land acknowledgement of Brantford. So here it goes. I acknowledge that I live on the lands and the territory of the Mississaugas of the Credit First Nation, Six Nations of the Grand River, and the traditional territory of the Atinwanderk Grand River Haudenosaunee. I am reminded that Brantford is situated on the lands that are full of rich indigenous history and home to many First Nations, Inuit, and Métis people today. And I recognize and accept the significance of their contributions to the past, present, and future as land keepers and water protectors of this land. Now, I took this quote from Cornel West. The modern Black diaspora problematic of invisibility and namelessness can be understood as a condition of relative lack of color, of power for Blacks to present themselves and others as complex beings, and thereby the bombardment of negative, degrading stereotypes put forth by white supremacist ideologies. Cornel West. So you see an image of a Black woman with a baby just recently birthed, and it says, I just did a dope thing and I will continue to do dope things. Having a baby should not be traumatic, but sometimes it is. So, yes, my name is Nanaya Yebua, also Bernadette. I have a BSCN in nursing and an MED in education, as well as perinatal nursing certificates, amongst other stuff. So this conversation is broken down into various models. So in model one, we're going to look at the history of Black female bodies in medicine, anti-Black racism in mental care. The reason being that you cannot move forward without understanding the historical impact of racism. We're going to look at perinatal mental health in Black women. One may ask the question, why not all women? Because all women in some, Black women are neglected, and Black women are not a homogeneous group. We are heterogeneous. So we're going to look at specifically Black women and delineate some of these things that impact us. So that covers for why the focus on Black maternal mental health. So we'll get into all that. In model 3, we're going to look at trauma in labor and delivery. That's where the PTSD comes in. Baby blues, postpartum depression or anxiety, postpartum psychosis, and stigma. In 4, immigration and childbirth culture. What does providing culturally responsive care look like? And then we'll look at research and stakeholders, community resources, and references is at the last. Um, the intention, so housekeeping, as usual, every time I'm having these conversations online, I make sure to let people know that it is a safe space. None of these conversations is meant to make anybody feel uncomfortable. So we are here because we need each other, to support each other, and want to grow with each other. Please do not share any private information because it's a live recording. And if you need to contact me, please do so by email, which is on the screen, philjo@live.ca. And the intention of this webinar is approximately 45 minutes, but it may take up to 60 minutes if I start sharing stories of experiences. So, being a Black woman and presenting, I come from a culture that looks at the past for a future of possibilities, which is Sankofa, going back to fetch what has been left behind. They that do not know their past will have difficulty moving forward. And also, creating the awareness of history gives us a deeper meaning and the foundation to work towards a future of inclusive care for all women. In this, we are learning to unlearn, to break down barriers, and to give a platform that everybody can utilize. So that is the Sankofa bird. So I've spoken about myself. For more information on upcoming events, you can go to the website, which is www.philjomultimedia.com. In the event session, you are going to have all this information coming out. And yes, I am most especially passionate about storytelling, Black women's mental health, and perinatal mental health. So a lot of the work that I do is around that. But most important, as a healthcare professional, what is it that I bring to the workspace? What is it that I am learning? What is the input that I'm inputting into myself to teach other new nurses through mentorship or preceptorship? And also, how do I relate this to the clients I take care of across the board, irrespective of color? The overall learning objective of this webinar is that by the end of this webinar presentation, the learner will be able to, number one, identify the historical impact of racism in present day Black maternal care, have a deeper understanding of the differences within immigrant populations and access to care, or synthesis of the Canadian healthcare system. Be able to understand the cultural components of the immigrant population and its influence in healthcare access. Be able to utilize self-reflective methodologies such as active listening, mindful speaking, empathy in providing care for these women who may be immigrants, whether by choice or by force, such as refugee, or say students who are here without the proper paperwork. They came to study but they got pregnant, and the challenges. Have a deeper and comprehensive understanding of the blues, postpartum depression, and psychosis. And the learner should be able to advocate for clients in the healthcare system. Historical impact of racism on Black birthing mothers. So before I even go into this model and what drove me to actually put this webinar together was a conversation I had with one of our nurses that I worked with in Toronto. And we were reflecting on some of the physician attitude, behaviors, and treatment of Black people. And what came to light was that some of us stood by, and right now reflecting on it, I highly regret it. Some of us stood by where some Black women were sutured without anesthesia. We stood by and listened to other, people call Black women as having attitudes, as being difficult to work with in labor and delivery. And as much as other people were saying it, the saddest part of it is we also believed it until I started learning about people's narratives and pulling back and taking time to assess and listening to people. Then I broke out of that. Some we did allow to happen because we thought you're a Black woman, you can withstand pain. But birthing itself is painful. Given the opportunity, should they go through that? And the answer is no. So these are part of the reasons why I put this webinar together, that I did not advocate for these women during those times, but it is different now. So if I have reflected upon and realized this and done the research and seen the narratives of these Black women and validating their experiences within the healthcare system here, which part of this education is missing? So this webinar is to bridge that gap, create the opportunities for us to have these critical conversations, because when you go to many of this say seminars around, the majority of the conversation is not is on the wider community, but where does that leave us as Black women, as Black narratives? So this is where I come in to do my little quarter on teaching and education. So in this, we're going to learn what the role history plays in our lives, positive or negative, the neglected women in our healthcare services here in Canada, and what is anti Black racism and its impact on the birthing woman before, during, and after the child is born. Because remember, this is tied into mental health, and everything that happens before, during, and after does affect women here. We'll delve into the concept of obstetric racism and its impact on Black birthing families. An understanding of and awareness of their history and the structural discrimination is to help drive a change in the practice for safety. Why Black maternal mental health? According to the research, Black women are twice as likely to experience maternal mental health conditions, but half as likely to receive treatment. So in 2024, March of Dimes did the research and came up that about 40% of Black mothers and birthing people experience mental health issues. One would think having a child or a baby should be a happy occasion. But here is it now that we are realizing that this is part of mental health that it goes undiagnosed, is not being looked at. And many, say, therapists and psychiatrists don't even have the capacity to, unless those that have taken it upon themselves to specifically focus on perinatal mental health disorders, which this conversation falls under. Over 50% of the postpartum depression cases in women of color go unreported. And this is by the Black Maternal Mental Health Alliance. And suicide and overdose are the leading cause of maternal deaths in Canada. According to the Canadian Perinatal Mental Health Collaborative, 1 in 4 Canadians are dealing with or affected by perinatal mental health. So 1 in 4 Canadians are dealing with or affected by perinatal mental health. So, as a healthcare professional, it is my role to advocate for all birthing peoples. However, as a racialized Black woman working as a labor and delivery nurse, it is also my responsibility to both advocate for the families, point out the bias care, racial and stereotyping of Black birthing women and their families. So, whether you're racialized or not, if you happen to take care of any Black woman within the healthcare system, have an understanding that there's implicit biases, there's structural biases that are ongoing, and racial stereotyping that people are not aware of. So you need to check yourself. So, just like I previously commented, that suicide and overdose are the leading cause of Black maternal deaths in Canada. Here are the statistics that 1 in every 4 Canadian families self reported perinatal depression and anxiety. So, women who become depressed after they have babies or anxious, am I doing the right thing? Do I have the capabilities to take care of this baby? And all those start questioning themselves, or whether they are worth it to be mothers. We'll go deeper into perinatal depression and anxiety in Model 2. According to the data in Canada, we've talked about suicide as being the fourth leading cause of maternal deaths. Now, the changing statistics is also influenced by immigration, refugees, women with comorbidities prior to pregnancy. When I say women with comorbidities due to pregnancy, for instance, if they already have physical challenges, emotional challenges, mental challenges, financial challenges, anything that stresses them. Overall, there's not enough statistics for Black women in Canada, but overall, around the world and particularly in the US, the care of Black women gives us a sneak peek into the care of Black women during labor and delivery. The stories of experiences of Black birthing women also gives us insight into their treatment. And when you speak to some of these women, they will tell you, I don't like that doctor. I don't like this hospital because this hospital doesn't treat us well. This doctor doesn't treat Black people well. And these are the experiences of these women, and they are validated. So let's go to understanding Black maternal mental health. Black women have an increased risk to perinatal mental health disorders because of increased trauma throughout their lifetimes, physically, emotionally, psychologically. Increased risk factors for maternal mental health disorders due to high levels of trauma exposure and greater barriers to assessing mental health. Increased exposure to trauma if they are refugees. It depends on whether some people may have been refugees coming to Canada, but they did not have to be in refugee camps. So, depending on the social, political, and economics of their pockets, that also has impact on them. Let's talk about anti-Black racism in healthcare, because without all these grounding understandings, talking about the rest is just scraping on the surface. This is digging deep for us to understand, and then we can work towards making things better. So, anti Black racism refers to attitudes, beliefs, stereotyping, discrimination, and prejudice targeted at people of African descent. Now, people of African descent does not mean only people from Africa, but say Jamaica, the Caribbean, and any person of color who is deemed of African descent. So we're talking about people from Africa and its diaspora, wherever that diaspora extends to. Influence of racism in healthcare education is either minimal or lack of educational instruction. And I will tell you that in my years of going through nursing school, there was almost nothing, just a sliver, and then that was it. Or say Black history, and then, a little bit of whatever, and then that is it. But in depth education of all these was not there. And at the end of the day, who is teaching it? My instructors were all white. Were they going to teach this? This was not their focus. So I made it a point that, for instance, during my preceptorship with students, we dig deep and talk about racism, talk about ourselves, our attitudes, our beliefs, our stereotypes, our biases, and how they affect care and what the expectations are. So, as we're talking about anti-Black racism in healthcare, we all I discussed earlier with say impact on Black female bodies, suturing without pain numbing medications, or yelling at women to stop moving while they are in pain, threatening to walk away. And I've seen some doctors do that. I have seen doctors do that, and that is not fair. That is not right, and that is traumatizing. And women have perceived racism in healthcare, most especially when they're not being listened to or seen. So that is a big problem. So, obstetric racism is when a woman is in labor and has a sense of being dismissed, objectified, and degraded, dehumanized, traumatized, and the paternalism with their care. So, the doctor comes in, either a male doctor, and tells him, okay, this and this and this and this is what he's going to do, without the woman having a choice as to what a say in their care. So all these things also do impact them. Or sometimes you have grand motives come in, a gravida 7 para 6, or has 9 children, and we look at them like they are breeders, pardon my language. So that is dehumanization of care, not looking at the person as a human being, but as, for instance, quote unquote, a breeder. And this goes back into racism, whereby Black women and men were used as breeding, as stock. So we need to be very mindful that this dehumanization is part of a historical problem. Therefore, as healthcare professionals, it's imperative that we understand the experiences of racialized persons to provide safe care. Within the general group of Black people, we also have to understand that different cultural underpinnings, that Black people are, sorry, it's supposed to be Black people are heterogeneous group of cultures. We are different. We are a conglomerate of different cultures. I believe I alluded to the history of obstetric racism. So, obstetric racism has a long history, which is embedded in the history of medical experimentation of enslaved women. It is the same with the concept of racism. So, as stated previously, obstetric racism often constitutes of untrue beliefs, unjust and prejudicial beliefs, and care practices or actions taken towards pregnant and birthing Black women. Like Black women can withstand a lot of pain. Not all of us can withstand a lot of pain. If the Black woman needs a epidural, give her the epidural. Not all of us can withstand pain, and we don't all have to be, how do we call it, a strong women to go through it. If you need your epidural, take it. This stems from a history of victimhood where enslaved women were used as experimental subjects in gynecological surgeries without pain management. This was premised on the belief that Black people have high pain tolerance. So, these acts of injustice, fueled by history of reproductive and medical exploitation of the presidents, form the precedent for how Black childbearing women are expected to be treated or behave within the healthcare system. And that is what I alluded to, that we as racialized women who are also nurses caring for other Black women fell into this bias without thinking twice or without having this understanding of the reproductive and medical exploitation and how it has influenced obstetric racism. So this is where I really want racialized women who are nurses or nurses in general to take note of. Become aware of the history, and that history should guide you to a present and a future to provide safe and equitable care for these women. The manifestation of obstetrical racism in healthcare is often subtle and of overt ways, which may include neglect, dismissal of concerns, disrespect, performing non consensual procedures. And some of these non consensual procedures may be sort of like you are doing a vaginal exam and you just tell the woman, I'm going to check you. That is intimate. You have to seek permission. Is it okay if I do a vag exam to assess? And let the woman say yes. Or say if they need to do an episiotomy, it needs to be communicated in a way that seeks permission from the woman to be aware that it's going to be done. And also surrogate decision making, which means the physician or nurses or the healthcare professionals make the decisions for the woman. No, include them in their decision making. It is their bodies, it is their choice. Let them have a say. Other experiences of obstetric racism is in the form of implicit biases, discrimination, stereotypes, and microaggressions within healthcare institutions, which hinder Black women's access to appropriate, safe, and quality reproductive and maternal health care. All these significantly impact on maternal health outcomes. Um, the other reason why I decided to put this together is that there is a lot of Black maternal deaths, most especially in the US, which is a developed, quote unquote, developed world, which is alarming. Why are Black women being dismissed? And in them being dismissed, it's causing a lot of chaos within the families, within the broader community, and that calls for us to become aware, to listen to women, Black women, Indigenous women, and take care of them. I do believe Black women and Indigenous women may have similar issues accessing healthcare because invisibility in healthcare, these women report feelings of not being seen, not being heard, being dismissed, ignored, neglected, stereotyped. And I've gone through all this previously. So therefore, they are dehumanized in their care, in their health care, which is a reproductive injustice that women having no say in their care. And yes, in the past, Black women have been sterilized without a say in their care. They didn't know. So that is not right. The lack of therapeutic relationships, which is lack of empathy by healthcare providers. I know we're all overworked and exhausted and everything, but sometimes all you need is the 5 minutes to say, girl, I hear you, I see you, right? We also have to be aware of the unequal power between the clients and the care providers. And what does it look like? So, what it looks like is that when a person comes into the healthcare institution, basically you have access to their intimate part. You have access to every part of them. So it's places that a power imbalance. So you need to be aware of that. And when you work within that scope, that you are working as what is the right word I'm looking for? As collaborators in their health. So patients with mental health challenges and other forms of disabilities may feel disenfranchised. Because sometimes when we see that people have, say depression or anxiety and everything, and they come in to deliver, it's like, how am I going to deal with this? It's like, I can't do this, I can't do. We already formed prejudice and bias in our minds before even having conversations with them. So my personal experience is that I don't look at that. I really need to talk to the patient. And when I hear the patient and listen to their story, that is where I take it from. Poor people may feel uncared for due to judgment in appearance. Well, it's not everybody that has it. Some people may come and they don't look too good as per how we expect them to look good, or they don't smell too great and everything. So we look at them as, it's like, do I need to care for this person? Yes, you do, because they're human and they need the same care. So be mindful of how you care for them. So some of the racialized stereotypes of devaluing descriptions of black mothers who've experienced prejudice include being scolded or belittled by healthcare professionalized, infantilized like children, when the healthcare professionals speak to these women like they're speaking to children. That is not right. Assumptions of drug use or abuse. This in turn leads to women being reactive, defensive, or having an attitude. Um, I laugh at that because everybody has an attitude. But if you understand where they're coming from based on these assumptions and biases, which they've experienced almost all their life, they always have a wall up, and you need to break that wall. You need to get in, you need to listen to their story and provide them with the care that they need. There's also the assumption of avoidance of utilizing care, and those assumptions of being less than educated and being on welfare. So these are all some of the racialized stereotypes that Black women face or go through. These are examples, but not an exhaustive length of it. So sometimes you say, it's like when I remember in the past, I working in Toronto, and I see black women come and they're ready. They will cuss you out. Now, what I did understand with that, they come that way because of knowing that there's a power imbalance, and they feel that you've already judged them. So they already have their walls up, defensive attitude, and they are advocating for themselves because they're not going to let you drag them through the mud. So having that understanding, going in and talking to them, having a conversation, it all breaks all these, stereotypes. Remember, every relationship is a two-way street. So how you treat them and how they respond is up to us. And also, our reaction is like, I do not want to care until it is too late. That is a wrong sense of thought. So here's my suggestion of some of the ways to provide meaningful care across cultures. Providing meaningful care across cultures here in Canada, we are highly diverse. So you may get Indian, you may get Iranian, you may get Afghanistan, Syrian, Jamaican, Ghanaian, anybody from anywhere. The question is, how do you provide non judgmental care? You take people as they present their story or their history. Your responsibility as a healthcare professional within that space or as a nurse is to provide emotional support, to be mindful and sensitive. To be mindful and sensitive. For instance, in the past, when, you know, we've gotten women from, say, Somalia who have undergone genital mutilation, um, sometimes it's like, ooh, and this is what is done. Remember, there was a cultural meaning to it for them. So you have to be mindful when you are having a conversation about that. And you also need to be sensitive because you're not doing it and you do and you speak and you are insensitive, it creates, you hurt them, you hurt their feelings. So be mindful and sensitive. In that, you also have to be self-aware of your cultural, social, historical, or political biases. Because we don't share the same culture does not mean my culture is better than yours or your culture is better than mine. So we all have to keep ourselves in checks and balances to provide that kind of care. When we're also providing care, we also have to listen with intention to understand. Listening with intention to understand means that we listen, you ask questions to break down what is being said, to understand exactly where they're coming from so that you can meet them there and you can provide the care that they need. One cannot, kindness and compassion, that is one of the key aspects of nursing. But unfortunately, I don't see a lot of kindness and compassion presently because of our biases towards other people. So when you're also having conversations with your clients, you have to be present away from distractions, technology, or otherwise. And yes, at certain times while speaking to clients, I've told them to put their phone aside and look at me and talk to me. Because if they are distracted and I am distracted, that means there is going to be a missing conversation. So, having that 5 minutes, 10 minutes time of having these conversations whereby we have a human connection of having conversations, that is part of caring across cultures. So, I do hope that at the end of this model that you have come to have a greater awareness and understanding of the cultural and racial stereotypes that impact care, and also an understanding of the role of history, how history play in our lives, whether positive or negatively, through systematic and structural biases. The intention was also to create an awareness of the Black maternal population as a neglected women in our healthcare services here in Canada, and creating an awareness of anti-Black racism and its impact on the birthing woman before, during, and after the child is born. More so, delve into the concept of obstetric racism and its impact on Black birthing families, and also understanding of and awareness of history, and to drive change in practice for safety, and also drive policy and teaching. Okay, we are going to delve into the next session, which is culture and childbirth. culture, childbirth, and trauma or PTSD in childbirth. Yes, women also experience PTSD in childbirth. So, as part of this model introduction, I did talk about blacks as a heterogenic group earlier in one. We're going to talk about the immigrant experience, which I looked at the refugees here. Background of traumatic life experiences, for instance, sexual abuse or circumcision, which is female circumcision. Sorry, I should have put that there. And the cultural expectations in childbirth, that some women have had children in other cultures, say in the developing world, and when they come to Canada and have babies, the culture shock. The culture shock most often than not occurs when they find that the obstetrician is a male obstetrician who is going to deliver them, and they're used to a culture whereby midwives did deliveries, and in emergency it is the doctors that did a c-section. So then the cultural expectation in childbirth was that it was a women's affair, but in North America, you have more male obstetricians than female. And language barriers, because of high diversity, many people don't speak English as a first language. So going through the language barriers to do your teaching and education for these women may be challenging. And then we look at trauma in childbirth, which is a huge thing. Whether the experience of going through labor changes immediately, and we have to do a start C-section, an episiotomy have to be done, or the woman has HELP syndrome, eclampsia, etc. So when all those dynamics changes, they also have a traumatic impact. Humanization culture and childbirth. So childbirth, as we all know, is a natural human process. In Canada, it is highly medicalized. This removes women's agency and autonomy over their bodies and processes. And that is what I spoke to earlier, that in some cultures, yes, it's a women. Midwives do the work, and in emergency, the doctors are called to do the, how do we call it? To do a C section if need be. So call the midwife, that is what they know, or call the older woman who has delivered a lot of babies in the community, or what we may call as traditional birth attendants. So different cultures go through the childbirth processes differently. Contained and constrained in a medical institution makes things difficult, or having husbands in the room during childbirth. So many women having husbands in the room during childbirth is a Western thing that they come to meet. In many developing areas, it is still women in women's affairs. And it's women in women's affairs because, number one, say you are delivering at a community clinic, there may be 4 or 5 other women also there pushing or delivered at different stages in labor. So yes, they will not allow any man there, but they will allow your mother, your sister, your grandmother, the women in your family to come and be with you to support you through that process. So when a woman has come from that kind of environment to the Canadian environment, it makes a little things a little bit difficult for some, but for some too, it's heaven. So it depends on who is you speaking to. Postpartum care after childbirth also differs. Some cultures keep their women enclosed for up to 6 months post birth. The foods eaten immediate post birth also differs, and some women are whether women are allowed to drink hot or cold things, using hot water to clean or press on C-section wounds, of vaginal tears and lacerations. We do cold compress, or ice on vaginal tears and lacerations, but in other cultures, it is the opposite. So understand that all these are coming into play when we take care of women from other places. So when you understand that the childbirth traditions and expectations differ around the world, it gives you a better handle on how to care for these women. And I'll highly suggest that you have conversations with these women, what the experiences were, what their grandmother's experiences were, what their mother's experiences were, and then you come in with what the expectation is here and how you can best help them, assist them as they go through this journey. And this is having, caring for, my practice has been Canadian for the most part, unless going away to, say, some part of, say, Sierra Leone to do that. But my practice has been specifically here in Canada. And as part of that practice, I have had the opportunity to care for women across the board from different corners of the world, including Kazakhstan. Only God knows, right? But at the end of the day, you got to understand that they're coming from different traditions. Ask what is done, what is expected. How can you best support them and their families, and then work with them in that way. So the when we talk about black women, for instance, here, and they are of a refugee status, depending on their socioeconomic background, refugee status, whether they stayed in a refugee camp, may have different experience than somebody who came through a refugee status, for instance, ended up in a developed world such as Holland and had a child in Holland and decided to immigrate to Canada. So their socio-economic status also plays a role in their expectations. I did not add religion here, but religion, also influenced by culture, also play a role in the expectation. Uh, the so in aspects of religion and some cultures, you get some women requesting for specifically female doctors, and that is some of the challenges that we tend to face here, with the lack of teaching or understanding that whoever is on call is the person that does the delivery. So that, in a sense, in reference to childbirth as a woman's domain, black women may not access care because they feel one being judged. And this, I'm talking about black women who are refugees, black women who are looking for their having challenges, black women who are, for instance, came here as students and for one reason or the other ended up being pregnant. Um, International students who do not have money to pay for their care. So all these, economic factors also impact childbirth. So whilst we're doing that, it is important that we, as care providers, be able to provide attention as much as we can, be compassionate in care and care for them. Provide, be kind, increase intuitiveness, our awareness to clients' needs and changing situations, and have a little bit more time with women in, most especially in the busy centers. With midwives, low risk birthing women love midwives because they are able to return home safely a few hours after birth, at least 6 hours, with midwifery support a phone call away. So let's look at the vulnerable populations and childbirth. So we've talked about refugee women as one of the most vulnerable population groups accessing healthcare. And this refugee women, I'm specifically speaking as Black women who are here as refugees, so either from Somalia, from Kenya, from Ethiopia, from whichever part of the world that they came through to Canada as refugees, they do have challenges accessing care, which includes understanding Canadian context of childbirth and sometimes how we encourage skin to skin care, skin to skin, the kangaroo care. In certain cultures, as soon as you have the baby is taken away and washed and fully clothed. But here we love to do skin to skin care. So that is something that often needs a lot of conversation as to expectation and the reason why it is done. So far as you're able to do that education and they understand, you get a yes. With language barriers, use of professional interpreters, if and when available, is better than nothing. In that whatever is being done is communicated across effectively in a professional manner as best as possible. Now, the refugee population are vulnerable because of lack of knowledge of available resources, and the where they tend to congregate is also high level, socially underfunded and resource areas, and they tend to have weak social support. They either here alone or single parent living in metro housing. They have limited access to culturally and linguistic appropriate information. And so this affects some of them after childbirth, whether vaginal delivery or versus C-section, after they had the baby, how they also bond with the babies. So let's talk about trauma in labor and delivery. I need to apologize. The labor in some aspects have OUR and in other aspects have OR. One is American OR and OUR is the British way of spelling. So I need to apologize for that. I just saw that. Birth trauma refers to any physical or emotional stress or distress a woman may feel during or after childbirth. For example, they may feel afraid, helpless, or unsupported by people around them. After the birth, they may have a feeling of guilt or numbness. And this often occurs when there's a sudden change in birthing plan without adequate conversation. For example, a start C-section may cause a stressful and frightful situation for birth and families due to a sudden decrease in fetal heart rate or an abnormal fetal heart rate. So, what does this mean? A start C-section is when baby is in distress and baby needs to come out. When women have in their minds that everything is going safe and they're going to have a vaginal delivery and a start C-section is called without them knowing the reason why, or in our madness running around, we tell them baby's heart rate is that we need to go for C-section right now. Sometimes they need a minute to process, but we don't have a minute for them to process. This is where somebody have to say, pause for 1 second. I know we're rushing, and this is the reason why we are rushing. And whilst we are doing X, Y, and Z, please think about it with your family, and daddy, and then you know things will be done. So for me personally, in my practice, I often, when having conversations with women right off the bat, apologize before we anything. I apologize for the things we will do and the things we will not do. If we go crazy because of a start section and I am unable to give them the information, I apologize ahead of time and I will answer any and all their questions. So I make it a point to have conversations, cover as much as possible, so that in these areas that conditions changes, their stress level is mitigated because they know that we've had that conversation. And when it happens and they see me the way I am, they know that it is for the safety. So my little suggestion is have time to have conversations, listen to your patients, their fears, their aspirations, their expectations, and then work through. Sometimes trauma happens because maternal birthing conditions changes the start season or get have a stroke, and they have a stroke because their blood pressures are very high, pregnancy induced hypertension, eclampsia or preeclampsia, or say placental abruption, etc. So after the birth, some of these women may be left feeling guilty or numb due to events beyond their control. And the family may be traumatized by this as well, the husband, other children, grandparents, and partners. So trauma in labor and delivery, what I didn't put in here is that sometimes there's a fetal loss when babies die whilst we are taking care of them. That is also traumatic. I didn't put it in the slide. It has to come in. So, as a support person, it is important to understand that trauma in childbirth is experienced differently for different women, and that manage expectation and explain processes in clear language, explaining the pros and cons when expectations are not being met during labor and delivery, and give the patient a listening ear and room to vent. For instance, some women want epidural, they request for epidural, the unit is busy, they don't get epidural. Take the time to explain and coach with breathing. If you don't do that, they have a sense of being ignored, and no one likes to be ignored, most especially when they are in labor. Unless they tell you they need their space, then you give them their space. And then feelings like decisions were made for you, loss of control. Sometimes when we need to start oxytocin, we just say we are going to start the oxytocin. No, you have a conversation. Why are you starting the oxytocin? And if they need to give you the go ahead to start the oxytocin. To prevent this feeling loss of control and traumatized, you let them think about it, mentally process it, and then um, come back. So we've talked about a sudden change from a vaginal delivery to emergency C-section, feelings of being unheard and mistreated intentionally or unintentionally by healthcare team. So this is why I say you need to be mindful of the tone, language, word choices, and stance, body language. Our body language gives away more than you could imagine. Also, as a healthcare professional, you have a sense of what their resilience is or lack thereof. Some women and families need more support than others, and be mindful of underlying mental health issues, mood disorders, anxiety, depression, panic attacks, etc., which this conversation is about. So the history, the trauma, the culture, everything is all tied into Black maternal mental health. All these do affect them. So my advice to Black women in labor or accessing healthcare is don't be afraid to ask questions and get answers. However, many may come from societies that have vast power imbalances between doctors, nurses, and the patients. And this sometimes comes to play that the doctor knows everything. We all don't know everything. So, if the birthing person had a child in some parts of Africa, an induction of labor will be referred to as forced labor. And let me tell you, the first time I heard forced labor, I almost got into a heart attack myself, because even that term forced sounds really aggressive. So when you say that, when you say there's going to be an induction of labor, they get scared. But you need to break it down as to why it's being done, the pros and cons, and give them room to ask questions. Limited healthcare accessibility. Some women come in with no prenatal classes and prenatal care. So if they did not go to prenatal classes, they have no idea what to expect. And most often in the younger population, the teenage population, they are at a higher risk of mental disorders. Different expectations of childbearing practices in Canada versus where the person is migrating from. And we have talked about male obstetricians versus midwives, and fear of hospitals and C-sections, not being able to work after epidural. So there's so many information on TikTok or what or in from part of the developing world, most especially about epidurals and the trauma that women have when they hear about epidural, or the fear of C-sections, because they've heard from wherever that they come in that women go have C-sections and they don't return alive. They're dead and their children are dead. But this is the conversation I have with them. It is not that, it is because access to care is very late. They come in when they are in crisis. So don't come in when you are in crisis. Come in and let's take care of you. So doulas, midwives, culture, and birth. Some women prefer midwives and will come with their doulas. That is fine. At the end of this is resources in the GTA area. There is a Black Doulas Association for Black women accessing Black doulas. There is Black midwives also that practice ancestral hands. So if you're in the GTA area and you prefer as a Black woman to have a Black midwife, they are there as well. And there are Black doulas who will have some understanding of where you're coming from. And sometimes all we want is to see we just want to see somebody who looks like us, who will understand some of the unspoken cultural nuances. Like when I suck my teeth, what does it mean for me as a Ghanaian? What does it mean for the next person as a Nigerian? What does it mean for my Jamaican, you know, client? We just want those nuances and feel like we've got somebody who can see us, who will listen to us. So that is why in the beginning, when I talked about those obstetric racism and biases, we need to be mindful of our implicit biases as Black or racialized nurses taking care of other people, because we often perpetrate it without even realizing that we are the ones perpetrating it. Now back to doulas and midwives. So doulas and midwives help empower women in their birthing experience. They help with less medicated birth experience because they are one-on-one, there's care and their attention. Women are not forced or rushed to get epidural and able to assume any birth position they prefer. And as we know, the lithotomy position is one of the difficult positions, but then within the healthcare institution, it is the position of birth. However, if you have a midwife or a doula assisting you, whatever position you want to assume, you are able to assume, and that is okay. The doula support also helps advocate for the women. Their sense of agency is supported. Feeling safe with a care provider who looks like them, mental and physical safety, and cultural understanding and competencies, being present and listening and offering emotional um, support. I remember years ago, I worked with a Black doula and with an Indian couple, and it was the Indian couple were looking for a doula. They couldn't find anybody of Indian, but they found a black woman. And when I went in and the doula saw me, her face lighted. This Indian couple also face lighted. And the question is, it's like, okay, what do you want to do? How do you want to do this? He said, I want an unmedicated birth. It's like, I don't want to use a epidural. I said, okay, so there are various ways we can do that. You can walk, you can, dance, you can do the shower. Everything that is needed to support her was done. At the end of the day, I asked her, so what kind of music do you want to listen? She says, any music. I said, then we are going to dance the baby out. And that is what eventually we ended up doing at 8 centimeters or 9 centimeters. Got her back into bed, and we did a beautiful, beautiful delivery. So that the support of the doula made my work easier in providing her that extra support, because the doula was there for the husband and the birthing woman and was close, and I could support and coach all of them. Now, that is to say that not all doulas are good, but then that is a conversation for another day. So, postnatal PTSD. So, this is post trauma that we're not talking about. So, it was formally recognized in 1990 by the American Psychiatric Association, and it changed its description of what constitutes a traumatic event. So that postnatal PTSD can be defined as an anxiety disorder that develops after a traumatic birth experience during pregnancy, which is losses, miscarriages, neonatal deaths, stillbirths, and then postpartum infants admitted to NICU, etc. According to the WHO, every day in 2020, almost 800 women died from preventable causes related to pregnancy and childbirth. And I didn't mean to add, I threw this part in because we want needed to know that maternal death occurs almost every 2 minutes. That was in 2020. So women die in childbirth. A childbirth that is supposed to be an engaging, a happy event, but women tend to die in childbirth. According to the research, women who had little to no support during childbirth increases the rate of PTSD, post traumatic stress disorder. So if women have little to no support during the childbirth, their rate of PTSD increases. And remember, language is everything. The way we speak to people matter a lot. Okay, so I hope that you have come out with something from this webinar, having a clearer understanding of Black populations as a heterogenic population with different cultural experiences, the role of midwives and doulas in providing care for Black birthing people, navigating cultural expectations and childbirth, understanding trauma in childbirth as a personal experience, and social and economic status, immigration status, educational level, and its impact on access to care, and trauma informed care in labor and delivery, postnatal PTSD. It's already an hour, and so we have come to. Yes, here are some of the community resources that you can look into. Canadian Mental Health Association has resources on mental health for perinatal mental health. Ottawa, Black Ottawa Connect. If you live in the Ottawa region, you can go on their website. They have connections to Black midwives and Black doulas in there that give support. Women's Health in Women's Hands here in Toronto also provides support and healthcare needs for women of refugee backgrounds so that they don't fall into the cracks. The children are also caught up. And I did mention Black Midwives, which is the Ancestral Hands. You Google Black Midwives in Ontario, Ancestral Hands will pop up. And Ontario Black Doulas Association are also here. In Scarborough is also Taibu, which is also geared towards, Black Health. So there are resources there. As I keep doing this, I am curating community resources, which at one point in time I am going to put out there so people can access it. I would like to say my thing is frozen. My screen is frozen. I stopped and my screen was frozen. Yes, yes. Hold on, hold on. It's supposed to stop. Oh.